caught the last part of your pre-session discussion. So nice to make your acquaintance. How do I pronounce your name, please? Dr. Wondwossen, is that correct?
Tekle is my last name, yes. Tekle.
Tekle, oh, Tekle. All right, so we'll leave it at Tekle, then that'll be fine. All right.
Yeah.
We usually wait a few minutes, just 1 or 2 minutes to get a few more people to join and to settle us in. The audience will be a mix, residents from my unit, and also we send this link out to, we have a Nigerian Neurosurgeons Forum, so we send that out to them as well, and we do get people join, and also colleagues from neurology and radiology also join, depending on what their schedules are like. So we expect a fair mix of participants today.
Great.
So,
yeah, thanks for having me, Dr. Bankole. Nice to meet you at the same time today.
Yeah, it's a pleasure. It's a pleasure. Pleasure is ours. Thanks for agreeing. So as we start, I'm delighted to welcome everyone to today's grand rounds. Thank you for joining us. By way of introduction, I'm Femi Bankole. I'm an associate professor and consultant neurosurgeon at the Lagos University Teaching Hospital. In our meetings, we have various stakeholders from various parts of the world joining us. Like I said, neurosurgeons, radiologists, some nurses, neurotechnologists, and sometimes we get some of our hospital admin staff in Lutz also to join in. We hold these grand rounds on a bi-monthly basis, and the title for today's grand round is Building the First Stroke and Neurointerventional Program in Ethiopia, and I'm excited to listen to that talk. Before I introduce the moderator and presenter for today, I would like to go through a few housekeeping rules. So we'll ask that when you join us, please mute your microphone unless called upon by the moderator or presenter. And when sharing video, be mindful of what's in your background. We like to say that we anticipate that we may have a few technological hiccups, but fortunately, we resolve this fairly quickly, so please bear with us. We will have opportunities to ask questions after the presentation. So if you have a question, you can just type it into the chat box and it will be read out at the end during the Q&A session. And if you'd like to ask a question directly, then during the Q&A session, please just raise your hand and you'll be invited to ask your question. Right. So our moderator today is Dr. Henrik Ullman. Dr. Ullman is a neuroradiologist, a neurointerventionist, and an assistant professor at the University of New Mexico School of Medicine. He earned his medical degree and PhD in neuroscience at the very famous Karolinska Institute in Stockholm, Sweden. And then he finished his radiology residency in UCLA. And he's a board-certified radiologist with the American Board of Radiology. Additionally, Dr. Ullman has completed a neurointerventional radiology fellowship at the Mallinckrodt Institute of Radiology at the Washington University School of Medicine in St. Louis. His professional interests revolve around technological advancements in neuroradiology and neurointervention, and expanding access to advanced diagnostic and therapeutic technologies in underserved communities. Our presenter today is Dr. Tekle. Dr. Tekle is a triple board certified physician and an associate professor of neurology and neurointerventional surgery at the University of Texas, Rio Grande Valley. He is board certified in neurology and vascular neurology by the American Academy of Neurology and CST certified in neuroendovascular surgery by the American Society of Neurological Surgeons. Dr. Wondwossen completed medical school in the year 2000 at the Addis Ababa University School of Medicine. He later moved on to the United States and completed an internal medicine internship at the Howard University Hospital and neurology residency at the George Washington University in Washington, D.C. Subsequently, he has completed 2 ACGME accredited fellowships, one at the University of Minnesota in vascular neurology and neurocritical care, and in endovascular surgical neuroradiology. Dr. Tekle also completed clinical research training at Harvard Medical School. He has authored or co-authored multiple peer-reviewed publications and book chapters in stroke, cerebrovascular diseases, and neurocritical care. He serves as a reviewer for multiple neurology medical journals. He's a senior member of the American Academy of Neurology, Society of Vascular and Interventional Neurology, American Society of Interventional Pain Physicians, and Society of Neurointerventional Surgery. So without further ado, I'd like to hand over to Dr. Wondwossen to go and with his presentation. Thank you very much, Dr. Tekle. Over to you.
Thank you so much for that kind introduction, Doctor. And first of all, I'd like to share, to thank Dr. Uche, Dr. Henry, and Henrik for the introduction, and for the invitation. And I really would like to share my experience as to what happened to my move to Ethiopia about 2 years ago. Excellent. Can you hear me well?
Yes, we can.
Yes, perfect. Thank you so much again. Yeah, so really this is how I have done it in terms of moving to Ethiopia and starting the practice. It could be a template for my other fellow Africans and or other practitioners in the third world or in low or middle income countries. It's kind of unique, but I am hoping that my experience will be used by my fellow Africans and others to establish stroke centers across Africa specifically. So yeah, I'm Wondwossen Tekle. I finished medical school in Ethiopia in the year 2000, and then moved to the US in 2004. Then starting 2006, I completed my residency and fellowships, trained under Dr. Qureshi at the University of Minnesota, and I had wonderful fellows, co-fellows. Some of them you might recognize, Dr. Hassan, for example. He was the immediate past president of the American Society of Vascular Interventional Neurology. So after finishing fellowship in 2013, I landed in South Texas. So when I landed in South Texas, as you can imagine, being from Ethiopia, I cannot be farther away from my home country, right? But I carried Ethiopia in my heart, simply because I went to medical school for free. I did not pay a penny. And I am only one of 2 Ethiopians to let me see this, if I could put this. I'm only one of only 2 Ethiopians to have been trained for neurointerventional surgical procedures or interventional neuroradiology. One is a neurosurgeon in the West Coast. She went to medical school in the US, but I am the only one who actually went to medical school in Ethiopia and then moved to the US. So really, I carry this big burden in a way of paying forward for what Ethiopia has given to me. So what I have decided to do is really one day go back to Ethiopia and then do something or pay it forward in a way that for my free medical education. For some of you who may not know, Ethiopia is the second largest country in Africa next to Nigeria, and Nigeria is number 1, 120 million people, second largest in Africa, and 11th largest in the world. So if you look at this stroke belt chart, Ethiopia is in that global stroke belt, and relative mortality from stroke is slightly higher than ischemic disease in Ethiopia, as it is the case in most African countries. This is corroborated by some local studies. Misgano et al. Published this back in 2012, showing that proportion of mortality increases by age or becomes more frequent for non-communicable diseases, as especially after the age of 45. You see this blue or black bars represent non-communicable diseases, and the gray bars represent communicable diseases. So if you just go beyond age 45, then non-communicable diseases become the #1 killers, and cardiovascular disease is #1 cause of mortality of all NCDs, and 50% of those mortalities are due to stroke. So these data were popping up as I was finishing fellowship and starting to practice. This was not the case when I was in med school between 1993 and year 2000. Non-communicable disease, especially strokes and cardiovascular disease, were very, very rare. We would be seeing, ST elevation MI on an EKG maybe every 2 months or 3 months when I was in med school, again, 1993 to 2000. But as you see, as the time goes by in the last 3 decades, cardiovascular disease are going up, are on the rise. Again, another local data is showing that non-communicable diseases, which is depicted as group 2 disorders here in the middle curve or in the middle graph here, they're taking up, especially from 2009 onwards. You notice that they're going up as compared to the first or the top graph, which is communicable diseases, and the bottom graph, which is injuries, which are also going up to some degree. But again, non-communicable diseases, of which cardiovascular diseases of our interest, are going up. Again, data collected as part of the global disease burden showing that premature mortality impact of stroke in Ethiopia is increasing. This data, published in 2019, shows that stroke is a number 5 killer, literally next to some neonatal disorders and some infectious diseases. Number 5, way on top of ischemic heart disease and others. If you consider the disease, if you consider the age group between 50 and 69 years old, ischemic heart disease impact becomes number 1. It's the number 1 cause of death or cause of premature mortality if you consider this specific age group. Leading risk factors attributing for stroke, dialysis in Ethiopia. I don't know why this graph is upside down, but if you look down, hypertension or high blood pressure is number 1, followed by particulate matter pollution. This is indoor particulate matter pollution, and then followed by high body mass index or physical inactivity and so on. These are some of the top risk factors for, for pushing stroke to the front and center of becoming a very important disease in a third world country like Ethiopia. Again, this data is corroborated by the WHO independent study, which showed prevalence of hypertension is as high as 24% here, and physical inactivity, which accounts to some degree for obesity in Ethiopia, which is coming up, is also up to 14%. Again, we used to be skinny guys. Now you see a lot of obese people going around. So this is interesting. So lots of data corroborating, local data, WHO data, global disease burden data, all of them showing that stroke is becoming an important disease. So given my background, the decision is, to go back and start a stroke or INR program in Ethiopia. The question was how? Now, there are 3 options: public-private partnership, and private options. As you know, Ethiopia, like most third world countries, majority are poor. So there's a lot of public hospitals which give free healthcare services. But over the last 3 decades, with the rise of non-communicable diseases, by the way, they also include cancer, infertilities, the strokes and cardiovascular diseases and injuries, all these NCDIs are going up. So a lot of private hospitals are popping up to complement or to supplement what is missing from the public hospital. So my goal is see if I can partner with a public hospital or a public hospital. When I mean by public hospital, the public hospital buys for everything. They say they invest in the equipment, they invest in the lab, they invest in the manpower. We would be going back and forth from the US to build a program. So we would be running the program, but the public hospital would be in charge of getting everything ready. And the second option is public-private partnership, which basically means the government that owns almost, most of the land and buildings in the capital city will give us a land and a building. We would then, the private partner would then bring in the cath lab, bring in the manpower to run the program and runs the program. And the third option is, of course, purely private option, which means we would be partnering with a private hospital in Ethiopia, in Addis Ababa, and then, then basically work in investing in the program equally, the US partner with a private partner in Ethiopia. So I started, communicating with the government informally since 2015, but this was one of the emails I sent in 2017 to one of the provosts of a major academic university hospital, asking him, I would like to establish a neurointerventional program in Ethiopia. How can we do this? And Subsequently, he arranged a meeting with the Minister of Health at that time, Dr. Amir Aman, in 2018. And basically, we had multiple meetings. This was just one of them. And we were sitting down and discussing how can we do this. And we were fleshing out the public option and then moving on to the public-private partnership. But as you can imagine, Ethiopia, a third world country, does have meager resources, and the government has to use those resources wisely, and in terms of allocating resources for healthcare expenditure. So without further ado, or just in conclusion, the public option was not going to happen because, again, lots of issues, war and internal politics and meager resources. So investing in a high-end cath lab and stroke program wasn't gonna fly very easily. And on top of that, mind you, this is 2018. In 2018, on a paper or this publication came out, November 2018 to be specific. This is from what's called an NCDI commission. This commission was commissioned by the Ministry of Health of Ethiopia. Basically, this commission was comprised of top doctors from Ethiopia from different relevant specialties. And their task was to review all major NCDs, non-communicable diseases, and then from epidemiology perspective, from the perspective of policy, and so on and so forth. But then after they did that, they would have to identify cost-effective priority interventions and advise the government on policy directions and financing. So this committee was put together in 2015 or 16. They worked for 2 years, collected so much data. They met multiple times, and they came up with this report, which was published in 2018. So in short, their task was to identify NCDIs and cost-effective priority interventions and advise the government. I'm sorry about this busy slide, but I will tell you the conclusion. Basically, they identified 235 interventions, of which 80 interventions, for 80 interventions, they were able to find cost effectiveness analysis. Out of the 235, 80 interventions, they were able to find cost effectiveness analysis. Now, listen to this last statement. Screening for cervical cancer, this is for women, and treatment of pharyngitis in children to prevent rheumatic heart disease are examples of very cost-effective interventions with cost-effectiveness ratios below $100. That's in 2012, per DALI averted. However, in contrast, acute management of stroke and peritoneal dialysis were placed among the least cost-effective of the considered interventions, with cost-effectiveness ratios above $30,000 per DALI averted. So this report was coming out as we were discussing this public option with the Minister of Health of Ethiopia. So you can imagine that this didn't go through very well. And then we moved on to PPP, public-private partnership. So then we said, okay, the government owns multiple lands and buildings, and the Minister of Health agreed, and he was going to give us, maybe a building or maybe half of a building in some academic hospital so that we could start the program. But public-private partnership is great on paper, especially for most third world countries. It is very difficult to implement. It was in its infancy at that time. They were just piloting it on some sectors like energy and transport sectors, just piloting it. They were not sure if it was going to work. And then when it comes to healthcare, they were just going to pilot it into imaging and laboratory services because they want to outsource those two services. And they were just testing the water at that time when we were discussing this. So really, PPP was not prime time to start, again, some high-end neurointerventional stroke program. So long story short, both options, after discussions spanning over 2 years, did not, were not going to be materialized. So finally, I went with a private and academic option. What I said to myself was, look, as long as I was going to teach, I was going to produce fellows, I was going to help, Ethiopia in that fashion. I need to take this program, and I'm going to take it in a private fashion. So that was 2018. Then COVID came. We moved in the fall of 2021. In the meantime, I had some homework to do in the US. What I did was I created a non-for-profit organization, which is called Ethiopia Stroke Initiative, which took about a year to establish. And then I also put together a group of investors, Ethiopians and non-Ethiopians also, to establish what's called Ethiopia Stroke Care PLLC, which is an investment company. The purpose of creating the Ethiopia Stroke Initiative nonprofit is now that I knew I was going to go through the private option, then I said, you know what, I have to help the poor somehow. How do I do that? Okay, maybe if this nonprofit has enough money in it, then I could support some patients who are unable to pay. Number one. Number two, at least I can support the fellowship programs, stroke fellowship, neuro-IR fellowship, salary for fellows and stuff like that. And also I said, you know what, at some point in the future, when a neuro-IR program is established at a public hospital, then Ethiopia Stroke Initiative, the nonprofit, will be helping establish that program. So with those things in mind, I started the nonprofit. But with the for-profit, the idea was the investment company was supposed to come to Ethiopia and make partnership with a private partner and start the program. So I did those, and then in between, and by 2020, I came to Ethiopia again and met the then Minister of Health, Dr. Leah Tadessa, and we started fleshing out the details of starting the program. And the Ethiopian Standards Agency is the one that basically approves practice standards for all kinds of specialties. And this was a snapshot of the Neurology Specialty Center practice standard. It's basically about general neurology. So what I had to do after discussing with the Minister of Health was to come up with a practice standard for neuro-IR, basically. This was divided into 4 premises. One is professionals. The second one is the premise. The third one is products. The fourth one is the practice itself. So I had to develop a practice standard based on a United States template. And I just put a snapshots of each one of them here for you. Basically, professionals is a minimum training for a professional. What should a neuro-interventional radiologist do? Whether he has a background from neurology, neurosurgery, or radiology, what should be the minimum training requirement? Premise is the cath lab. What should the cath lab has? What kind of equipment? What kinds of rooms? And so on. And I'm sorry, premise is about the cath lab environment in general, cath lab, equipment room, technical room, and so on. Product is about the cath lab, the single plane, biplane, blah, blah, blah. And of course, the practice is what kinds of procedures do we do in the cath lab and so on. So I developed this practice standard, again, based on a US template, and brought it back to the Ministry of Health. And they, commented on it and sent it to the Standards Agency to be incorporated into this one, the neurology practice standard, which was already existing. Once I did that, by the fall 2021, we moved to Ethiopia. Again, the investment company, which is Ethiopia Stroke Care PLC, now came down to Ethiopia to join arms with Samaritan Medical Services, which is a private hospital in Ethiopia. We merged and formed this joint venture company called Axon Stroke and Spine Center, which is the first stroke center in Ethiopia. So cath lab, biplane cath lab delivery time was supposed to be November 2021, as we had moved in September 2021, but actual cath lab delivery time was July 2022. So then I said, you know what, I'm not going to sit on my behind and do nothing. So let me do something. So while waiting for the cath lab or for the stroke program to begin, I'm also a trained pain management physician. So I started to do injections. This is a transforaminal epidural injection for some lady who had a L5 radiculopathy. And, I also do radio frequency ablations. This is an RF from Stryker on some guy who had facet disease. So I started to do things like this, run clinics, outpatient clinics, and so on and so forth, while waiting for the cath lab. But more importantly, I was training staff. I was recruiting and training people, staff for cath lab, staff for neuro ICU, staff for a stroke unit. It was really important to train these people extensively. I had time in my hand. I had 6 months or so while I was going back and forth between the US and Ethiopia to train a lot of people, to recruit people. It was very, very nice and helpful for me to recruit people, from relevant territories. For example, for a neuro-IR lab, I was able to recruit people from the cardiac cath lab, because interventional cardiology has been here for a while. So I recruit them and then train them for the neuro part. At least they have the cath lab etiquette. They know how to handle the catheter. They know the overall, safety of radiation and so on and so forth. All I have to teach them was about neuro catheters, neuro wires, and so on and so forth. So by the same token, for neuro ICU, I would recruit nurses and others from an ICU environment for general ICU, and then bring them to the neuro ICU up and teach them about EVD care, ventriculostomy catheter, and other things, which is specific for neuro ICU and neuro ICU patient follow-ups and so on and so forth. So I would highly advise recruiting, to your neuro program, people who have some relevant experience. But of course, we also recruited new people to tag along with those who are older. But it was very helpful to get the program up and running if you have some team members who have relevant experience. After we did that, October 2022, we were inaugurated officially by the then Ministry of Health of Ethiopia, Dr. Leah Tadessa. This is our center. It's Axon Stroke and Spine Center. This is how it looks. 2 stories building. The ground floor is clinics. First floor is ward. And the last floor, or the second floor, is where our cath lab and major OR and neurological ICU. That it was a GE biplane IGS 630 cath lab suite. From GE, this was delivered. Very nice, cool stuff, cool equipment. This is what I have been using for the last 11 years in South Texas. Although I trained on Philips and Siemens in Minnesota, at the Children's Hospital where we did pediatric interventions, it was Siemens. But at the other 2 major academic hospitals, in the trauma center and at the University of Minnesota, the main center, we had Philips. So, but when I moved to South Texas, it was all GE. So for 11 years, I used GE. It made sense to bring GE to Ethiopia because I know all the bells and whistles and all the stuff that I needed. So we brought that. And since then, we started our comprehensive stroke center care in Ethiopia. First mechanical thrombectomy, November 6, 2022. And guess what? It was a basilar arterial occlusion. Some guy who flew from Dubai to Addis Ababa, Ethiopia. His family are here in Ethiopia. He is a merchant in Dubai. He goes back and forth, but he stays in Dubai for several weeks before he comes back to Addis Ababa. The night he has some cardiac disease. He was supposed to be on anticoagulation. He did not take his medication for those few days, and he was drinking and having too much fun, I think, with his friends. So he had a major stroke. He became comatose while he was having fun with his friends, and he had a dense basilar artery sign. For some of you residents, that's your dense basilar artery sign, basilar thrombosis. And I tell everybody, and I believe in God, and I say it. All of you who do basilar thrombectomy, the outcomes. Maybe 40%, 30% good outcome rate. This was my first case. And he turned out to be good. And I told everybody then, this is my sign that God wants me to be in Ethiopia, because it could have gone bad. And, people could say, this thing doesn't work. But anyway, 3-4 days later, he's walking with support. And this was his thrombosis. Distal, mid-distal basilar thrombosis, and this is his pre and post angiography pictures. And another lady came 3 or 4 days later with right MTA syndrome. And that was her angio, right MCA mid M1 occlusion, pre and post AP and lateral. Great outcome again. So I had, those great days when I started. And then, of course, we gave the first TPA, IV TPA in Ethiopia on December 19, 2022 for stroke. This is the brand called Actilize, 50 milligrams vials. They come, similar to Activase, which we use in the US. By the way, we gave that first TPA for a German lady, not for an Ethiopian. A German lady who teaches in a German school here in Addis Ababa, Ethiopia. She had a stroke, at work, and then she came in quickly. Ethiopians don't come on time. I'll tell you about that in a little bit. So what kinds of digital platforms do we use for, transfers locally in the city? Yeah, I don't know if some of you know Telegram, some of you, of course, know WhatsApp. We use images, to send pictures from one hospital. Somebody sends me pictures through WhatsApp. WhatsApp is encrypted in encryption, so I think it's safe. And I even hear that it might be even HIPAA compatible. But yeah, we use WhatsApp and Telegram to send images from one to another and to ask for transfers. And that's what we do. We don't have Viz AI or Rapid, that's too much of a luxury for us here. But anyway, so how are we doing? So since then, we've been growing very well, and we've been working hard. We have done about 542 cases in about 12 to 14 months this time. I couldn't be sure. I've been open for now 18 months with Cath Lab, I mean. But I go back and forth between the US and Ethiopia. As some of you may know, I do work 2 months in Ethiopia straight for 60 days. And then I go to the US for 15 days, 2 weeks. I'm a part-timer in South Texas, so I do go back every 2 weeks for every 2 months for 2 weeks, which would be about 3 weeks because of the travel time and so on. So with those times missing in between, I think I would say this is a volume of about 12, maybe 13 months on average. So as you can see, we do a bunch of diagnostic angiographies. That's what keeps the lights on, right? I think Dr. Chris Moran says that, if I am not mistaken. You can correct me, Uche, if I'm wrong, but a 70-30 ratio or 60-40 ratio between diagnostics and interventions is good. It's healthy. And again, diagnostic angiograms keep the lights on, according to Chris. But anyway, spinal angiography is 5, aneurysm 70. I have done quite a few aneurysms, of which 13 of them are flow diverters. And of course, there is quite a good mix of stent-assisted and balloon-assisted coilings, but a bunch of them, I would say probably 40 of them or 45 are primary coiling. I try to primarily coil as much as I can. Even if it's wide neck, I do use 2 catheters. Whatever I do need to use, I try to primary coil them to decrease cost. But of these, 13 of them are flow diverters. Mechanical thrombectomy, only 26. Imagine, it's very low, and this is sad. I'll talk a little bit about this later on, but I should be doing more ischemic strokes than aneurysms. It's a no-brainer. But sadly, in Africa, in Ethiopia, every third world country in general, they don't come on time. They do not come on time, or either they're not ready, they don't have the finances. It's so many factors, but we don't do enough mechanical thrombectomies. Very, very sad. Anyways, AVMs and brain aneurysms and fistulas 13, and so on. Carotid stents 3, intracranial MCS stents 3, MMA embo 5, and I also do pain management, as I told you, transforaminals, those radio frequency ablations, about 99. So total of 543 cases. This basically shows the same thing, but just did a very rough, and don't quote me on this, please. It's a very rough estimation based on reports from industry and verbal communications. I try to show you that this, by this slide, that what does a sub-Saharan Africa comparison looks like. Ethiopia, Kenya, and South Africa. South Africa had about 15 programs. 5 of them are in Cape Town, and the rest are spread across Durban, Johannesburg, and Pretoria. And Kenya and Ethiopia have now 1 programs. Each Kenya have had a program at Aga Khan University Hospital by Dr. Mugere. He has a monoplane suite. He has been up and running since 2017. He trained in South Africa in Cape Town. Now, Dr. Mugere does about 10 thrombectomies per year. And in South Africa, they do about 150 thrombectomies per year. When you divide that for, among 15 hospitals or centers, it's about 10 per site. It may not be that 10 per site because Cape Town does more. But again, 150 per year for a country of 60 million South Africans is very sad. As opposed to aneurysms, we shouldn't be doing too much, but at least we have done 70. Mugere does 30 to 40 per year in the vascular. He also clips. I don't have his clipping volume in the neurosurgeon. And South Africa does about 180 endovascular aneurysm treatments. Again, 5 of them in Cape Town. So the purpose of this slide is really to show you that we don't do enough strokes. We don't do enough LVOs. This is a problem in Dubai, in India, across the third world. They don't come on time, unfortunately, or they don't have the finances. Okay, that's the for-profit or the investment part. Now, what does a non-for-profit does? it does sponsor fellowships. Now, these three stroke/vascular neurology fellows, they literally just graduated last week. They finished a one-year training with the US. So in the United States, there is a group of, there is a what's called a Merit Academy, which gives the didactics, the lectures. All the didactics come from the US professors, but the training happens in Ethiopia. The actual, the practice happens in Ethiopia because they go to the academic hospital, a major academic hospital, like University of Lagos. It's Tukur Ambassa, the main one in Ethiopia, in the capital. And then for the private, they come to me. So between the private and the public settings, they see enough cases. I am convinced that Ethiopia has more diverse cases than the US, 100%. Let me tell you the reason. Because Ethiopia has all kinds of diseases of what used to be the first world disease. It was diabetes, high blood pressure, the metabolic syndromes, all kinds of diseases, cerebrovascular diseases from diabetes, hypertension, we have them now. But we have what the US doesn't have, for example, rheumatic heart disease, valve damage, clots coming from the heart because of valve damage from rheumatic heart disease, and also vasculitis. I tend to see a lot more vasculitis here than I see in the US in my nearly 15, 16 years, including residency, fellowship, and as an attending in 11 years. So long story short, they have great case mix that they can apply their knowledge, but the knowledge or the didactics is given from the US. They are evaluated, and all the evaluation, the homeworks, the live web discussions happen from the US. So with that kind of technique or strategy, I was able to graduate 3 vascular neurology fellows. Now Ethiopia has 4 vascular neurology fellows, including myself. These are neuro-IR fellows. These are my 2 neuro-IR fellows, and they are now training with me. The guy on the left is a neurosurgeon. The guy on the right is a neurologist. I had him do both. This guy did vascular neurology fellowship, didactics and training, while he is also doing endo with me in the cath lab. I also have a pain management fellow. He is an anesthesiologist. So because of my US contact, for example, this is a Society of Vascular Interventional Neurology course, one of their core courses, ASCESED. This course is $100 per person. It was donated to my nonprofit, and I was able to train 69 doctors and nurses. This is my wife, by the way. She's a registered nurse, has worked in the US in multiple states. She's now our chief nursing officer, and she also took that test, and this is her certificate. So I was able to train a lot of nurses from donations like this. So you can connect with the training programs in the US and train your staff on the ground. So this is what the nonprofit does. So let me talk about opportunities and challenges quickly, and then let me wrap up. Ethiopia is a large country, 120 million people. It's an opportunity, a large country, lots of volume. There's no way, if someone works hard, you're not going to be successful because you have this huge population behind you, like Nigeria, for example, and Uche and Dr. Henry and all of you guys. You should not have problems. Yes, a lot of people are poor, but 10 to 15% of patients that can afford treatment, that's 20 million easily, 30 million people. And in the end of the day, even the wealthy or people who can afford treatment are also Ethiopians. They also need treatment. They also deserve the care they deserve. We don't always size things up by the poorest of the poor. We can, even the people who are in the middle class or people who can afford treatment should have, the access to care. So, going to Nigeria, going to Ethiopia, even to treat those who can afford is not a bad idea. Just as a side note. Anyway, it's the fastest growing economy in Africa. It's going to be hopefully a middle class by 2035. And primary health coverage has now reached 95%, which is good, which means people now can go, if the government can cover primary health coverage, then, for the secondary health coverage, so to speak, or for the more complex diseases, then people can find different kinds of sources of finances. So these are all opportunities. Challenges are many, though. Poor public health awareness, as I was telling you, of stroke, religious and cultural issues. I'll talk about that in a little bit. underdeveloped stroke system of care, unfavorable health policy, as I described to you about earlier with that report about cost effectiveness, poor healthcare financing, I'll talk about it a little bit, underdeveloped supply chain system, TPA, endovascular devices, and aggressive medical tourism industry, which wants to push patients out of the country because it's a big business. Sorry, I have had a cold the last few days when my throat is getting dry. So challenges are too many, guys, too many in Africa. Fear of healthcare complications because they have had it, they have seen it, honestly. Uche and I train in the US, and thank God we got this amazing opportunity to train some of the best institutions in the US. And yeah, we kind of know what we do and so on, but the vast, majority of the public have fear of complications. Or on the opposite, they have unrealistic expectations. They want every surgery or everything to have a good outcome, and they don't want to hear about it. They pay for something and they want, they want it back. But again, it's not the majority. It's not everybody, but majority think that healthcare outcomes are like they pay for something, they will take it. If someone comes for a subarachnoid hemorrhage, if you ask them to pay for aneurysm coiling, and they believe that if you coiled it means that the patient is going to walk out, but then you would have to tell them, oh wait, he had a subarachnoid hemorrhage, he's in coma, I'm coiling it because I don't want him to rebleed and die, but he has to still go through the subarachnoid hemorrhage complications by itself. And you know what, so trying to help them understand that can be challenging because they pay a big sum of money for the coiling, and maybe that's all they have. They don't have enough money to now carry this patient through the ICU care for the next 2 weeks. But anyways, medication availabilities, and they may not be up to par. As you know, third world medications may have problems. I'm using my own clopidogrel. When I do put intracranial stent or pipelines, I do not trust local, I'm sorry to say that, local clopidogrel. And I have my own eptifibatide and tyrofibans that I bring from the US for those cases where I do flow diverters and intracranial stents, because I don't want to blame it on the medication that may not work locally. But again, this is a big issue. Finances are a big problem. Cultural issues. I mean, people sit home assuming stroke will get better. The paralysis could be from evil spirit. They just wait for 6 hours on this 27-year-old lady who had a cardiac problem, rheumatic heart disease. She had a mitral stenosis. She formed a clot, went to the left MCA. Her NIH stroke scale was 27. They sat on her at home, assuming the evil spirit will leave her. But 6 hours later, the evil spirit was not going anywhere. And sadly, it's not a laughing matter, but they brought her to the hospital. By then, the whole left brain was cooked and nothing much to do. So a lot of issues. And then these things need to be addressed over time. It will take time. And they will tell you, oh, I don't want to take hypertension medications because I could get diabetes from the medications. I'm like, stuff like that is very rampant across society. So education is key. We have to do a lot of public awareness, a lot of public education to overcome some of these things. And we're doing our best. I'll show you. And this is some of the public outreach that we're doing. This was a National Stroke Week initiatives that we did. We give a lot of public lectures, set up, health fairs, measure blood pressure, sugar, and lipid panels, and try to teach the public by putting these things in the main public squares, and giving talks, university hospitals, and United Nations headquarters, embassies. American Embassy was this one. A lot of places we go around and give talks to try to increase awareness. We go on print media. This was one major newspaper locally that featured us saying unclotting city, one stroke at a time. And I was also on a lot of these local TVs giving talks about stroke and so on. So we're doing our best to try to increase awareness. Underdeveloped system of care, as I told you earlier, there are only 3 places, including my own. There's 2 major public hospitals which started after me to give TPA. And only 3 stroke units in Ethiopia of this large country. Only 1 neurological ICU, which is mine. Stroke neurologist, just me. Interventionalist, just me. Now, I should have edited this slide because this slide was made a few weeks ago. my 3 newly graduated vascular neurologists, they will have to come here, you know. I have to put them here while you guys are watching. Now we are 4. Thank goodness. How about that? But anyway, unfavorable health policy. Yeah, I told you earlier that this non-communication disease report about terrible cost effectiveness of stroke and dialysis, which is not true. As you know, a lot of cost effectiveness analysis done in the US and other parts of the world show that treating stroke is cost effective. But mind you, this cost effectiveness analysis was done before the new devices were approved, before the solitaires, the Trevos came to the market. I mean, at least their study was conducted in 2015, 16, 17. As you know, 2015 is when we have those great first publications coming out. So I wouldn't blame them because they were basing their cost effectiveness analysis based on old data. However, that needs to change. That needs to change. We're working with the government. For example, something that we're trying to do is working with the government for LVO funding. MOU we're about to sign, we're working, going back and forth. We're saying if they come to our center, we provide LVO, mechanical thrombectomy, at least pay for those patients who go to the right facility. But in the meantime, as I was telling you, we're setting up a trust fund to cover for the unfunded through the nonprofit. And I also use donated devices from the US to be able to not turn away LVOs that come to my door. And I have not. I have at least, devices enough to treat the next 100 LVOs, even if they're not funded. I made sure that I had that in place before I moved here. And that was a commitment that I did to myself. I'm not going to announce it because I work in a private hospital, but if somehow they show up to my door and they are eligible for LVO thrombectomy and they cannot pay, they will go get it. They will go get it. So let me tell you a little bit about public health financing in Ethiopia. From all the money that's spent on healthcare, the government pays only 30%. That's all the budget that's available. 36% international aid, 33% out-of-pocket expenditure. People pay out-of-pocket, and only 1% private insurance. And out of the 30% only that the government pays for, still a significant amount of that funding or that budget goes to treating communicable diseases, HIV, TB, malaria. Even if they contribute to 10% of the total disease burden, by 2006 at least, 21% of that budget goes to them. However, non-communicable diseases, which includes cardiovascular diseases, cancer, and other things, and injuries, 46% of the disease burden, but they get only 15% of the total healthcare spending. So there is huge discrepancy, a huge problem here that the government, with its meager resources, they still have to make some adjustments to make sure that stroke gets the attention it needs, and that needs work. But, practice like mine targets the last 2 bullet points here: out-of-pocket expenditure and private insurances. Again, as I told you, Ethiopia is a big country, Nigeria is a huge country, and people who can pay out-of-pocket and private insurance, these are like some tens of millions of people here. You can help them, and then you can come up with some strategy to help the poor. But healthcare financing needs to improve in Ethiopia and in Africa by and large. Again, terrible supply chain system. TPA is not available for purchase locally. And that's surprising because it's only after I came, I started to ask questions. Nobody asked it before that. So they don't have enough supplies, and COVID came. They are overstretching. Boehringer Ingelheim is the company, as you know. And they're telling me, I know the people, I know the top guys from my US contacts, but they're telling me they don't have enough bandwidth to expand, significant cells in Ethiopia, and they cannot. And in the process of registering their products and having a local distributor takes time. 9 months is easily. So because of that, I'm tired. I'll just go and buy them from Kenya or South Africa for now, but I'm working to get them sold locally. The same thing with endovascular devices, almost, except for some, scanty presence for Medtronic and others, I still buy them from secondary markets. So I go to Kenya, help my friend, Dr. Mgeri and others to see how they set up their practice. but at the same time, try to access for resources, buy TPA, this and that. This was my trip to Kenya. I have gone there multiple times. I also go to South Africa. This is Albert Lutuli Hospital, one of the major government hospitals where they do a lot of cases. Well-funded hospital, really, really amazing place. I think a lot of African countries can take example from this hospital. Very well staffed, very well funded, enough devices and catheters and wires available. They do a lot of crazy cases. This was one of the AVM summits that a guy from Spain came down, and I went from there. And then this is a local staff, people from all over South Africa, Durban, Cape Town, Johannesburg, came to one place. This time it was Durban, and we did a lot of cases at once. But again, a lot of regional collaboration. And medical tourism, there's nothing you can do about it. All you can do is just talk to them that we now have a stroke program. At least they would stop sending patients overseas for that. But they are budging to some degree. At least people were trying to take our case to the public, so that way we don't have much problems. But we also are focusing on increasing inbound medical tourism. Ethiopia is now getting a lot of patients from the neighboring countries, including Eritrea, Sudan, South Sudan, Djibouti, Somalia, and so we're getting a lot of patients from across the region. And I was awarded Sven's Neurointerventional Pioneering Award in 2022's annual meeting. And I'm very thankful. And I end my talk with this. Thank you so much for your attention. Sorry if I took more time.
Thank you so much, Dr. Tekle. I'm going to hand over to Dr. Allman to field the questions. Dr. Allman.
Hi, how are you doing all? Thank you very much, Dr. Tekle, for this fantastic presentation. I've followed the chat box, and I think we have one question on the indications for thrombectomy. What are the inclusion criteria you're using for thrombectomy candidates? Are you taking large core patients and patients with a higher premorbid MRS, 3 to 4?
So no, I try to stick to, classic indications for now. Patients who are coming 0 to 24 hours, aspect score 5, 6, or basically 6 and above, because and of course, as far as screening, I just use non-contrast head CT and CTA aspect. I don't have perfusion studies at all, so I will just base it based on CTA, and again, aspect score 6 or above, and strictly, premorbid functional status 0 to 2. But sometimes you can go to 3, and I know there are some debates about, whether we should take someone who was wheelchair bound and walking and having fun with family, suddenly became aphasic with left M1 occlusion. Would you take that person or not just because he's on a wheelchair? And, we always have that kinds of discussions. But the bottom line is I haven't done enough, sadly. In the US, in 2 weeks, I do more than what I do in almost almost a year in Ethiopia. We don't do enough strokes, sadly. We don't do enough thrombectomies. 26, imagine, in 13 months is all I have done. But because, again, if I have a lot of patients, I try to be selective. Now I will do anything, honestly, as far as they agree, up to 24 hours, low aspect. I don't have any problems. Now I have data to support me. I can take them. I have no problems. But the bottom line is they don't come on time. I don't have enough volume, unfortunately. But because of the expectations of patients, as I was telling you earlier, some people believe that because, they pay money, they want great outcomes. The thrombectomy outcomes at best are at around 50-60% nowadays, right? Even in the best studies in ESCAPE and all, we have up to 70%. 30% of the patients may not do well despite complete reperfusion. So, but people are not ready to, or not necessarily ready to accept that fact. So because of all that, I try to stick on indications and target patients that I can help. But again, the bottom line is we don't have enough volume, sadly.
Thank you very much for that answer. I have another question asking if you have been working with companies such as Stryker and Medtronic to add their devices to a pro bono portfolio to potentially supply these in an easier way to developing countries.
Correct. So first of all, they're not here. Most of the device companies that we know in the US are not here. For them to come, they have to take, first, they have to find a local distributor, and they have to vet multiple companies or multiple local agencies and companies, and they have to approve them after they have done their due diligence and vetting them extensively, because a big company like Medtronic, they just don't want to work with anybody. You know what I mean? Anybody, any firm in Ethiopia. They have to extensively, vet them and so on. That will take about a year or so. Then once they pick up a distributor, then that distributor would have to register Medtronic as a company and also Medtronic's products, all of them. This process takes about a year also, because what they do is the local FDA, it's called EFDA, Ethiopian FDA. They will just look at devices. They may want to go back to the Medtronic headquarters to see their manufacturing plant, see how things are done, pick samples, bring them back to a local lab, and then approve them. It's a very long process. I don't know how many of you know this. Now, because of this, Medtronic would say, if you are the CEO of Medtronic, you would think, okay, why would I go to Ethiopia? Why would I go through all this pain? How much business is there? Okay, Tekle is on the ground. He has how much volume? This much. Is it worth my time? So it really depends on both sides. The consumer side, us, for pushing Medtronic or other, Stryker, Microvention, Penumbra, all of them, to come on the ground and to reassure them that we will do the legwork to get them registered. But at the same time, they have to also be committed to say that, does it make business sense? And that's a challenge. That's a challenge. The reason I go around to create regional collaboration with Kenya, South Africa, and so on is, at least if we open multiple sites, multiple shops, for example, Nigeria, Ghana, and all these regional businesses grow up, they may have a regional office at least. They may want to come, and start their offices in town. But there is a big problem. There is a big, like Boehringer Ingelheim, the TPA company. They don't want to come. They know Ethiopia at 120 million, but they look at other African countries, TPA utilizations, and they say, why would I have to go through that much pain? So to answer your question, yes, I have tried. Yes, device cost is slightly cheaper. For example, if Solitaire, a thrombectomy device, is $7,000 in the US. In Europe, it's about $2,200. In Germany, England, because they are, a single payer system, they were able to negotiate prices down. When it hits Africa, in Ethiopia, it's $1,900. So it's overall slightly cheaper when it hits Africa, but it's not too cheap. They're not, just because you're in Africa, they're not going to sell it for you for $500 or something. So I don't know if that answers your question, but yeah, we keep working hard. We try to bring companies down. We try to push them to register. In the meantime, I go to regional markets to get my devices and products.
Thank you very much. We have a question from Shisoba Espue, who the hand is raised. Do you have a question?
Yeah, hello. Can you hear me?
I can hear you.
Hey, Wondwossen. It's nice to see you and nice to hear from you. I'm calling in from St. Louis. Sorry, I'm in between rounds, and I've been following up your conversation, and I must have missed a lot. And pardon me if you have answered this question. The biggest challenge we have in Africa, mainly in Nigeria, is the neurosurgical support. When you do neurointerventional procedure, sometimes some of them may go down south, and patient may need immediate neurosurgical intervention to rescue. For maybe 1 or 2% times that you may run into some complications. Do you get that readily available in Ethiopia? And also, how is the neuro ICU support for patients? Like I saw your case, I saw the patient with the basilar occlusion. and I don't think he was intubated. If my eyes was telling me correctly, usually I would not do basilar intervention without intubating the patient because you can go down south from there. So it's a wonderful thing you're doing to start with, and I'm very encouraged by it. Me being a Nigerian, yeah, I think we've spoken a couple of times in the past, and we're looking at you and hoping to model your style back in Nigeria. Thank you very much for your presentation.
Thank you so much, Dr. Ezekwe. You are a neurosurgeon interventionalist, I get?
Yes, yeah, neurointerventionalist. Yes.
Where, neurosurgeon or neurologist?
Neurology, just like you were trained same way.
Yeah, we spoke
7 years.
In one of the conferences, correct? We spoke
yes,
with one of
yes, yes, we did.
Excellent. Yeah, I remember you now very well. Yes.
Yeah.
Great questions. So that basilar occlusion, because the picture was taken just before he got intubated, because, whatever. But he was intubated finally, because that was a picture as soon as they brought him to the cath lab. That was the window that we had to take a picture. But after that, he was quickly intubated and we moved on to intervention. So we did intubate him actually. Now, going backwards to answer your questions, that patient ended up in the neuro ICU. Yes, what I did for my neuro ICU is, a neuro ICU is an ICU, right? That the only difference is that the general ICUs, for example, they don't do EBDs, they don't do EBD monitoring, and so on. So what I did was, they didn't even have monitors, the advanced hemodynamic monitors, for example, the IBPs, invasive blood pressure and invasive, pressure monitors. So I bought from China invasive monitors, IBP monitors that have number of IBP jacks, so that when we put EBDs, then we can connect them and we can measure intracranial pressure. So basically, it's a regular ICU with now the ability to measure ICPs, manage EBDs, and the rest is basically the same, right? I mean, of course, I don't have EEGs on the wall, and you can connect. That's high end, and that will happen in the future. But it's like a regular ICU with the ability again to monitor ICPs and so on, and then to do neurological exams frequently. Ventilators, everything else. What I did is I trained my team, my intensivist and my ICU nurses are all taken from, ICUs and other places. And I extensively trained them for care of a neurological ICU patient. As far as neurosurgical backup, as you know very well, it's overrated. I'm not trying to underplay the benefit of neurosurgical help, but for the neurointerventional practice, we even published this in the past. If a complication hits, all you have to do is really be able to put an EVD, and then probably do decompressive craniectomy. This a general neurosurgeon can do. You know what I mean? There's a bunch of them. There's a bunch of them in Nigeria. There's a bunch of them in Ethiopia. I have at least 4 neurosurgeons working with me, in my center only. And there's many of them who have privilege. So really, in the end of the day, you have to choose your cases carefully. What needs to be clipped should be clipped. What needs to be coiled should be coiled, and that happens. But in the event that you have complications, you have to plan ahead. For example, if it's a subarachnoid hemorrhage, put an EBD first before you take them to the cath lab. But God forbid something happens, then put EBD afterwards immediately. I typically put them in the cath lab. I'm trained to do them. I put EVDs myself because I'm a neuro ICU guy, and I put them in the cath lab. Or, a neurosurgeon can put it for you in the ICU, in the OR. Or if there is a need for decompressive crani, then they can do it for you. I mean, again, decompressive craniectomy is what neurosurgeons do when they are in their 2nd year of training, right? So really, for those are the only 2 interventions that could make a difference. You and me know that, nothing else. Whether you have a bleed, whether you have a hematoma, what do? You just do EVD and then decompressive crani. But again, choosing your patients carefully and avoiding complication is the most important thing. It's more like, remember when cardiologists were doing, left main stenting and angioplasty, they used to always say, If a cardiologist is intervening in the left main coronary artery, there has to be a cardiothoracic surgery backup. Remember these days? And then the cardiologists fought back and they said, you know what, there's no need, honestly. Now they're doing left mains everywhere. I'm not suggesting left mains they probably should be bypassed technically. But my point is, if they do LADs and others, they used to tell them that you have to have a cardiothoracic surgery backup. But those things are, losing favor because one of the studies that we did in Minnesota is that if someone had a complication, then what was done afterward is how much, or if the neurosurgical backup was going to be necessary or not, or if it would actually make a difference in patient's outcome. It wasn't a big deal, to be honest, to be very honest with you. So I don't want you to be intimidated by that. But again, for the neurointerventional practice, you need a basic neurosurgeon who just finished school, who can put an EVD and do decompressive cranio, suboccipital decompressive cranio for cerebellar issues or posterior fossa issues, and frontal bifrontal cranies. And those are, again, a basic neurosurgical skills.
Thank you very much for that answer. For the next question, we have a question. If you think having a vascular neurology background is optimal versus neurocritical care, neurosurgery, or radiology, what's the most important for your role?
Yeah, I mean, I think, all backgrounds are necessary. They have their own great qualities. I have had issues with my neuroradiologists here, for example, because there are not many. At my center, I don't have a neuroradiologist because I try to support most of the reading myself, at least a stroke and others. I'm still looking for a neuroradiologist because they are in short supply in Ethiopia. But if someone has a neuroradiology background, it would be awesome because you have someone who reads images nicely for you, CTs, MRs, and others. He can bill for those services on the side while he's doing intervention. So that's an amazing quality that you need. If you have a neurology background, vascular neurology is very good. But if you have neurocritical care background, it's even better because you can manage your patients in the ICU. You can help the critical care person manage your patients. Sometimes things get complicated, as you know. So I would say with a little bit of more favor towards neurocritical care background than vascular neurology. But in the end of the day, my vascular neurology, fellowship was done in the ICU, in the neuro ICU at the University of Minnesota. So we basically, it was an ICU fellowship, so to speak, because we were in the ICU all full time. So if you have enough ICU experience, that should be good. That's where I learned, to do everything, putting EVDs and all that stuff, because our fellowship was really ICU based. The neurosurgery, it's a no-brainer. It's helpful, of course. Then you have all the tools. You can clip what you can clip. You can coil what you can coil. That's an added advantage if you are a neurosurgeon. So each subspecialty brings some value to the field. So everyone is important, I think.
Thank you very much. The next question we have, I think we may have a little bit of time, is whether or not you have room in your training program in Ethiopia for people outside of Ethiopia.
Yes, I have been asked multiple times from people from Zambia, Congo, and also from Malawi. The thing is, I am new. I am, as you have seen, 18 months only with a cath lab. Although I've been here for 2 years, my cath lab came late, and I am trying to teach, at least produce 2 or 3 fellows who can help me cover the gap. And as you know, volume is important. I did 690 angiograms, DSAs, diagnostic angiograms, in my first year in Minnesota, 690 when I finished first year, and that was important. And then, of course, second year, I did a whole lot. So I finished with over 1,000 cases when I finished fellowship. And honestly, with a hands-on program like Minnesota back then, it was very helpful for me to hit the ground running. Day one in South Texas, I was, doing a 2-millimeter aneurysm in Tangad. I was ready for that. The reason I say this is because volume matters to train fellows. With the volume I showed you, I can only support 1 or 2 fellows per year. And I'm obviously giving priority for Ethiopians because I want them to help me when I go to the US to fill the gap, the 2 weeks, 3 weeks gap that I'm leaving behind. Once I have at least 2 or 3 fellows trained here, and then now we can cover each other, I take a break, and then I will be open to accept applicants from outside of Ethiopia, because 1, I have more than me to teach. 2, I will have more volume, because by then my program will have expanded and I will have more volume coming in. At this point, it's new. My supply chain is not perfect. I sometimes keep some cases for another day because I simply don't have enough onyx on my shelf or enough glue on my shelf. Seriously, I just had a big shipment now 2 days ago from South Africa, and I'm now ready to take on all those AVMs and stuff that I have kept. So long story short, I will be very happy to entertain that idea after I train a couple of Ethiopians.
Okay, thank you very much. I don't think we have any other questions in the chat. I have a question. Has there been any use of TNK or discussion about using TNK in Ethiopia? Because I figured that it may be easier in remote areas and easier. The dosing is easier. So I wonder if that's something you have discussed or tried to bring on.
Absolutely. Great question. You read my mind, because I said, you know what, if people cannot afford mechanical thrombectomy, maybe they can afford thrombolysis. And if I have to give them thrombolysis, I would rather give them the more effective one. I know there's a debate about which one, but yes, single use, more, the TPA clot sensitive, it works better, up to 25 to 40% sometimes recanalization rate, even for LVOs. So I said, you know what, I want to give TNK. Why would I even have my poor Ethiopians spend money on TPA if I can give them TNK? But it's very expensive. It's very much unavailable in Ethiopia to begin with. But as I buy my stuff from secondary markets, I go buy TPA and TNK. TNK is like 3 times more expensive. And I buy TPA for about $650 to $700, the 50 milligrams vial. Yeah, I know it's much more expensive, nearly $7,000 in the US, but for a 70 kilograms person, you would have to open 2 vials because it's 1 milligrams, 0.9 milligrams per kilogram. Then 2 vials is just buying price is $1,300. Then the markup, whatever markup, 15%, 10%, 25%, whatever the hospital marks up, you can imagine for TPA, you would have to ask them to pay $1,500, $1,600. So that's expensive for most Ethiopians. Instead, I said, let me give them TNK, but it's not available. It's 3 times more expensive. So unfortunately, TNK is not prime time for Africa, for at least Ethiopia. I don't know why it's 3 times more expensive than Alteplase, or we call it Actylase in Ethiopia. But I definitely want to.
Yeah, that's a great answer. Yeah, hopefully in the future.
Yeah.
I think that's all the questions I have for now. Is there anyone who have any other questions for Dr. Tekle before we continue?
I think nobody's hand is up and time is sort of running out.
Yeah. Okay, so I thank you very much, Dr. Tekle, for this presentation. I also want to thank Dr. Bankole for hosting this Grand Grounds, and thank you very much, Dr. Bankole, for advancing neurosurgery in Nigeria and everything you've been doing. And for me, I'm very excited about being part of this this initiative. I did my fellowship with Dr. Okafo, and I've been trying to be involved. I have another work also, which most of us do, but I'm very happy to be part of this. I'm part of the West Africa Stroke Initiative, and
Great.
we're Dr. Okafo and Henry is working hard on this, and additional information about WASI will be presented in future sessions, and we're very happy to have you all here. And with that, I want to hand the mic over to Dr. Bankole for closing the presentation out today.
Thank you so much, Henrik, for having me.
Thank you.
All right. Thank you so much, Henrik. Thank you, Dr. Tekle, again. It was really fantastic presentation and very practical. I mean, we could see how you negotiated, and some of those stories resonate very much with with me, and I'm sure many of the audience is here, many of the people in the audience, because we share the similar circumstances. So we'll definitely be tapping your experience and your resource, both virtually and physically, as we move on. Our next grand round will take place on the 10th of April. The poster for that is being shared on the screen right now. Please take note of the details, and we look forward to seeing you there. Please feel free to invite other colleagues. We had at the point up to 64 people joining in. If you have any ideas for topics that you would like presented in future sessions, please get in touch with Dr. Okafo or myself. Today's recordings, the recordings for today's presentation will, as well as previous recordings or recordings of previous grand rounds, will be uploaded to the YouTube channel of the West African Stroke Initiative. So you can check that channel and enjoy the presentations from the past. I want to thank everyone for joining us. We hope that the session has been valuable. The link for the YouTube channel has been posted on the chat, and we look forward to, continue to collaborate to make this a reality also in Nigeria. Hopefully in 2 years' time, we'll be able to talk about our experience also. Thank you all so much. God bless you. Have a wonderful.
Thanks for having me again, Dr. Bankole.
You're welcome.
I see that Dr. Jagadisan is coming to talk. He was my, he came to Minnesota in my last year of fellowship. So after from St. Louis, he was like Dr. Okafo. Dr. Okafo today was Jagadisan in 2013. It was my senior. He came from, WashU to Minnesota. So he was in my senior year. So I was with him for 1 year, and then I went on to become an attending. So yeah, so he's awesome. He's good.
All right.
Yeah,
so
thanks,
we look forward
everybody.
to that session.
Yes.
All right. Thank you, everyone. Have a wonderful day.
Thank you, everyone. Thank you.
Thank you so much.